Well, FLT3 has been an important target in AML for many years now. As soon as we learned what it was, it's common. It really is perhaps the most common driver mutation. And if you're an AML doctor, you're dealing with these patients constantly. They are, shall we say, exciting patients. They come in with very high white count, they relapse, they occupy a lot of our clinical time. And there's a very obvious tantalizing target. As a treating oncologist, the more drugs I have to treat something with, the better. So I'm thrilled that we've got potentially lots of choices here. Each of those drugs that you mentioned has its own strengths and weaknesses. And so each of them are going to be important in our fight against this disease in overlapping ways. So at one end of the spectrum is midostaurin, pan-kinase, sort of very multi-targeted, partial inhibition of lots of kinases, including FLT3. And at the other end of the spectrum is highly selected, very potent quizartinib. And then you have these fascinating drugs, crenolanib and gilteritinib, which are what we call type 1 inhibitors. They are very selective in their own way, but they are active against what we refer to as resistance-conferring mutations in FLT3. They're less potent than quizartinib, which is at the one end of the spectrum, but they probably have a broader spectrum of activity within the FLT3 AML population. All of them have warts, shall we say, tolerability or whatever, something a little bit wrong, but all of them are going to be useful potentially. If I had my choice, I'd want them all approved.